Yes, Captain.
Okay, thank you, sir. So, welcome back, everyone, once again to another interactive session of our foundation course in palliative medicine. Today, we'll be continuing our discussion on aspects of communication with today's focus on handling pollution and breaking bad news. And it is indeed my personal privilege and pleasure to be welcoming one of the very few most charismatic and vibrant personalities I have come across in my professional life, Mrs. Smriti Rana. So, for formal faculty introduction for the session facilitation, I hand over to Dr. Sudha. Sir, over to you.
Thank you, Sripriya. And good evening, everybody. In the last class, we had a session on basics of communication. Now we'll move on to some common situations which we face in palliative care. Usually, these are uh, how to communicate bad news to the patient. And if a family member asks us not to communicate diagnosis or prognosis to the patient, what shall we do? That situation is called collusion. So, how can we manage collusion? And we know that we would not be comfortable when the patient has anger or patient cries or any other emotions. So, we'll try to also deal with in general how to deal with the emotions. So today we have Smriti Rana, who is the head of policy and strategic division at Palim India. Basically, she is trained as a psychologist, but due to her experience in her family, um, she started working in palliative care since 2001. And thereafter, she had worked in palliative care in various capacities. Uh, and she particularly works to make availability of opioid analgesics in India by collaborating with the central government, as well as she is the liaison officer between the WHO Collaborating Center of Palim India and WHO Southeast Asia Region Office. And she has been a spokesperson in various international forums for Palim India, like Vienna, um, Vienna NGO committee, then WHO, and in various forms of WHO. And she's also involved in WHO technical expert committee to decide on the how we can assess and monitor the palliative care provision in various parts of the world. She has special interest in death literacy, appropriate end of life care. Then she also is interested in advocacy groups with people with lived experience and the role of storytelling in humanizing healthcare. And she also represents Palim India in various forums like International Association of Hospice and Palliative Care. And she's also a board member of International Drug Control Policy Consortium. Welcome, Smriti, and it's over to you.
Thank you very much. And thank you for inviting me for this session. I have to say that I am slightly intimidated being in this group of extremely accomplished people. I have looked at the attendees list, and I'm hoping that at the end of this session, it's a session of mutual learning for all of us, including for me. So I'm here to lead you through a session on communication, and especially difficult communication. Although Dr. Sunil and Shripriya have talked about collusion and managing difficult emotions, I'm going to try and just bring it all together in this 1 hour using a case study, and then we'll just go through the different aspects of it. So I would encourage you to please use the chat box for reflections and questions. and comments. If you have any, I will stop from time to time to sort of look at it and address these comments and questions. If there are personal reflections or if there are personal instances that you'd like to share, if something is coming up, I would request that those be saved for the end of the session, because when something personal is shared, it becomes difficult to not address it while continuing with the session. Although if there's something important that comes up for you, I will encourage you to please share with the group. So I'm going to just get started for now, and we'll see where this goes. Okay. So we tend to think of communicating bad news as just communicating a fatal diagnosis, but then the communication of bad news happens at different points of the illness trajectory. And the communication of a diagnosis itself is communication of bad news. So I just want us to bear that in mind, that we're not just talking about communicating bad news in the context of communicating a terminal prognosis. It is also in breakpoint conversations that we have along the way as things start changing for the patient and for the family. So, you know, with, say, the failure of a particular intervention or the outcomes not being what we hoped they would be, those are also significant moments for us to consider how are we going to have these conversations. So just to set the tone for that, and I'm sure you've come across this, the single biggest problem in communication is the illusion that it has taken place. Sometimes we feel like we've communicated what we need to communicate, but for some reason it has just not landed with the person the way we think they should have received it. And we've been trained to communicate in a particular way. We've been trained to maintain some sort of emotional distance from our patients. We've been trained to use a particular set of sentences or medical language in order to communicate something. But is it really being received by the person in a way that they need to receive it? That's a whole other story. So let's be mindful that what we are saying is actually being received by the person on the other side of the conversation. There are 3 levels of clinical decision-making. I would actually reframe this to say shared decision-making or decision-making as a whole. And all of you work in healthcare settings, so you know what this means. But I just want to sort of underscore this point that there are 3 ways to actually include a person in the decision-making for their illness, for the setting of goals, for whatever it might be. One is that purely medical. We're just giving them information. This is the diagnosis. This is what that diagnosis means. These are the treatments that are usually given for this kind of a condition. And these are usually the outcomes of that treatment. So this is just information. The second level is a little bit more, well, paternalistic is the word that is used, but I would say it's a little bit more than just giving information. It is also giving recommendations. This is your diagnosis. These are the treatments available for the diagnosis. These are the outcomes. With my experience and with my patients, this is what I would typically recommend for you. So it's one more level beyond giving just information. The third is shared decision-making. And this is the ideal scenario. I know this is not always achievable, but good practice would require this. So it's giving the information, it's giving the recommendations, but also checking to see what are the values and preferences of the patient and the family. And this is something that we are trying to include them in. So this is the diagnosis. These are the treatment options available. These are the known outcomes. This is what I recommend. Can you afford this? Are you in a position to undertake this course of treatment? Do you have caregivers around you or social supports or the finances to go through with this? And then to arrive at the outcome. This does not mean that if the person is not able to afford certain treatments, that we're just going to give them suboptimal treatment. It's not that, but it's to help them arrive at something that they're able to sustain. There's no point in saying, okay, this is the treatment for this kind of cancer. It's going to require 8 rounds of chemotherapy, so many fractions of radiation, and it's going to cost so much. The patient says, okay, is that the best option? Yes, in my opinion, it's the best option. The patient starts. 3 months later, they're broke. They've mortgaged their house, they've sold some assets, and they can't afford the treatment anymore. Then what that's going to result in is some degree of anger is going to result in nothing good, really. It's going to result in doctor shopping. It's going to result in non-compliance. It's going to result in all kinds of things. So to really sit with the family and say, okay, this is what you have, this is what is recommended, but what is acceptable, affordable, and accessible to you? And let's arrive at a plan of care that takes into consideration all of these different things. Okay. And the red arrows to say that's the preferred mode of decision making. Okay, so I'm just going to take you through a case study, and if there's anybody in the group who would volunteer to read this case out, it would be great. You can just unmute yourself.
Case study,
Yes.
75 years old Mrs. D, complaints of shortness of breath, diagnosed with rapidly progressing idiopathic interstitial lung disease, brought to the hospital with the history of acute exacerbation, prescribed medications, steroids, morphine, laxatives, and pulmonary rehab. ADLS drastically affected, requires round-the-clock O2 support, repeated secondary infections, requires palliation, family prefers home care. After a severe exacerbation, physician decided to shift the patient to ICU unit. The vitals begin to fail, and the resident decided to put her on artificial ventilation without the consent from the primary caregiver. A day later, she passed away. It was clear to the doctor and the primary caregiver that she was likely to die. However, the primary caregiver is angry about the artificial ventilation and feels it went against the family wishes.
Thank you very much. I'm going to give you all a moment to just read through this one more time. Okay, so I'm going to stop sharing my screen so I can interact with all of you better. I'm just going to ask you, what stands out for you in this case? One or two things that might stand out. You can use the chat box, you can unmute and maybe point it out. Let's keep it brief. What stands out for you in this case? Something that is touching a nerve, something that maybe is making you think twice about whether it was right or not. Okay, patient died.
Generally, in most of the cases, the family prefers to shift the patient to ICU, and the doctors willing to have a home care. But in this scenario, it was the other side around, where the family prefers the home care, and the doctor, in an other way around, has shifted to the ICU. And in this way, the patient, the patient has been demised. So the caregivers were a bit angry that they have not shared their quality time in the last moment with the patient. And this has been snatched by the doctor, despite being known that he won't be survived for more, he will be survived for days. It could be for hours or the days, despite knowing that he has the quality time been snatched. So this was a bit angry kind of situation arised in this scenario.
Thank you. I'm glad you pointed out that this is an unusual scenario where it's the family that has decided on home care. It is unusual.
Smriti, there
Yes.
are many chat responses also.
I've got that open. Yes, Dr. Sunil.
Yeah.
I've got that open. Thank you. So yes, but I am going to take a moment to say that it is unusual, and that itself takes the healthcare system by surprise, doesn't it? That, oh, so you want to do home care, and okay, fine, so we'll do this. I can see rapidly, I can see the chat box rapidly getting populated. So I think we all agree that in the patient and family's wishes were not considered. There was an expressed desire for home care, etc. Unnecessary aggressive interventions. Relatives were not informed about the treatment against the family's wishes. They went to the ICU. Okay, fine. So I think it's all pretty much saying similar stuff, unless anything is drastically different. Okay, yeah. So I think we're all agreed that the communication, there was a communication breakdown. I would say that the communication breakdown happened maybe towards the end. Notice that it was the resident who put the patient on the ventilator, not the physician. So there's a breakdown of communication there as well within the healthcare system. It seems like up until that point, the family and the healthcare providers were pretty much on the same page. They decided on home care. There was oxygen support at home. The patient was being taken care of at home. But somewhere, this breakdown happened. And the primary caregiver, who likely up until that point, because it says even the primary caregiver knew that this person was likely to die. So why is she angry? Because at the very last crucial minute, the most important time, this decision was taken away from the family. Yeah. So we're going to be coming back repeatedly to this one particular case scenario. But if something does strike you in maybe a different scenario, maybe the person had cancer, or maybe the person had a CVA or something, that let's discuss that as well. Okay, so we don't have to stick to this case, but we will use this as the guiding case for this.
Ma'am, if I may, in an ICU setup, often split-second decisions are taken if the patient is deteriorating. So it's often happened that the patient has been put on a ventilator, and then the doctor or the registrar goes out and tells that, oh, his or her saturation was or the vitals were like plummeting, so we had to do 1, 2, 3. It's often, including putting medications like an adrenaline pump or anything, something like that. So I don't know whether what transpired here. So
we're having this conversation at a very interesting time if you're following the Supreme Court proceedings. And some of you are talking about the validity and the legality of the do not resuscitate, the DNR. I would say, let's go back to the fact that the family and the patient have expressly said they want home care. Yes, an acute exacerbation, which was not manageable at home, they moved to the ICU. But in the course of this treatment, those split-second decisions, Dimple, that you're talking about, was there no wasn't there any sort of instructions within the team that if this were to happen? Today, we're talking about withholding and withdrawing futile interventions. It is not, in a case like this, where there is no possible good outcome, then maybe that was a conversation that should have taken place. Yes. So yes, split-second decisions are taken, and it's going to take us a long time to, for the healthcare system to work around that. But in this case, the problem is that this was expressly stated right from the start. It was agreed that this particular case did not have the chance of recovery, and at this point, things were pretty futile. So that's where it is, and I'm happy to discuss this a little more as we go along. And to the consent aspect, it is by law, but it doesn't always happen. And we can talk about the legality of the DNR some more later as well. Okay, I'm just going to go back to the presentation. Thank you all for your your inputs, and we'll keep coming back to this. Okay, now first thing to consider. There are several considerations, and these considerations come in at different times, right? At the time of diagnosis, is there a clear understanding by everyone concerned, by the treating team, by the caregivers, by the patient not always, because of the collusion that we're talking about. Patients are usually the last to know the full extent of their prognosis or their disease condition. What are the potential trajectories that this illness can take? And the second part of the sentence, unfortunately, doesn't happen in most settings, but because we are palliative care people, we put this in. Is there a role for palliative care? Ideally, there is a role for palliative care right from the start, even if it means having conversations, if not medical interventions. And if the and this is a common thing, when someone is given a very serious diagnosis, there is a tendency for doctor shopping. Okay, I'm going to just get another opinion. Or worse, let's check with Dr. Google what Dr. Google has to say, and then come back to my attending team with Dr. Google's recommendations. And let's forget the fact that all my doctors here have gone through years and years and years of training. So diagnosis, these are some considerations that you're going to have to consider, right? Now, in the treatment phase, Does the patient and the family, do they understand the effectiveness and the implications of the treatment that you are prescribing, whatever those treatment interventions might be? And do we know what the impact is on the disease, and not just on the disease, but on the patient and the family? How is it going to affect the patient's quality of life? If the patient has to undergo chemotherapy and be fatigued for 2 days afterwards, do they know this? Do they know, does the family know that there's going to have to be a permanent caregiver on standby? Does it mean that it's a very expensive treatment? And can they afford it? Like I said, values and preferences. Can you afford this in the long run? Does somebody in the family have to give up a job in order to become caregiver, further exacerbating the financial distress? How far away are they from the hospital? I mean, you know, I'm going to just pause for a second. Yeah, I don't have that other presentation handy, but there's a picture of this young man who, he's in our home care, you know, he's being taken care of by our home care team as we speak. And he was a 20 or 25-year-old boy. We went over to his house, and he'd just been sitting there, not very active mentally or, you know, vocally, and certainly not able to move around very much. He had been in a road accident three years prior. And he was told that he needs physiotherapy. And that was what he was told, and he would improve. But this is the state we found him in, because where this boy lives, and he's about 5 feet 10 inches tall, he's pretty big built. His mother was his only caregiver. He didn't have a father. His house was on a little hill, 2 hills away from the main road. For him to be taken to the hospital for physiotherapy, 4 full-grown men from the village had to take half a day off, put this guy on a khatia, carry him a kilometer to the main road where there was no bus service. So the mother had to pay 400 rupees to put him in an auto, take him to the physiotherapy and bring him back, and forego her wages for the day, spend 2 weeks worth of wages on this treatment, and then bring him back. Impossible. But the prescription is so simple now. Physiotherapy once a week. So 3 years later, the home care team finds him. Home care team goes, does very innovative reverse innovation, puts up parallel bars in his house. He's able to start moving around a little bit with his mother's help, eventually by himself. He's a lot better now. But this simple thing of values and preferences, affordability and accessibility was not asked. Are, how difficult is it for someone to come for physiotherapy once a week? Yeah, impossible for this family. But it also says that there was not a two-way communication in this at all. It was medical decision making. Here's what you have. Here is the intervention. That's it. So this is to talk about, you know, taking into consideration the affordability, accessibility. What are you prescribing to this person? And are you, by this prescription, inflicting more suffering on this family than taking it away, which is what we're trying to do. Nobody is trying to inflict more harm, but inadvertently, sometimes we do that. So that's the treatment side. Okay. Does the family understand what it's going to cost them, not in terms of just money, but also in terms of their energy, in terms of how much they have to invest in taking care of this person? There is something called direct care and something called indirect care. Direct care is what I do to the patient. I give them a bath, I feed them, I give them their medicine. Indirect care is the stuff I do for them. I go to the bank on their behalf. I get some papers sorted out for their subsidies. I make sure that their children are taken care of. So does the family understand the full picture of what this is going to entail? Prognosis. What do we want out of this? We want this person to be able to maintain activities of daily living as far as possible. We want them to be as independent as far as possible. We want to certainly control the disease. Do we know at what point treatment becomes futile? If we do this, if it comes to this point where they're no longer responding to, you know, the first line, second line, third line, when do we stop? Where does the patient want to be cared for? What is the support needed in order to be cared for in that setting? And what is the access to palliative care in that setting should curative treatment eventually become absolutely futile and there's only room for palliation? Okay, so this is for us to be considering at every point, and this is what will inform the conversations that we have with these families and with the patients. Okay, now who decides? There are cases where the patient decides. This is more of a Western concept, I think, not so much culturally present in our context, although there are exceptions to the rule, of course. And in that case, when the patient decides, it's provided that they have all the information and decision-making capacity. The patient may have to decide also because they're alone, they don't have caregivers. But do they have the information in order to make the right decisions for themselves? There's another case where the patient will decide who decides. This happens a lot. No, my son-in-law is going to make these decisions for me. It's up to my daughter. She's the one looking after me, let her decide. Sometimes it's the person who controls the finances will decide. And that person may not be the primary caregiver. The primary caregiver might be a very disempowered third daughter-in-law of the house. Whereas the person paying for the treatment is the son who lives in Dubai, who has no day-to-day interaction with the patient. So we as healthcare providers need to understand who is making that decision and why is it that the patient has chosen that person. The last is when the family decides. There is no discussion, or there is no discussion, or no one decides. Doctor, you decide, please. Okay, and in that case, patients' wishes and preferences are certainly not considered. It results in emotionally charged decisions during a crisis because there has been no discussion. Decisions are made on the spot and usually controlled by the emotional climate. In the orange box, I forgot to go over that. If somebody else has been made a proxy, then conversations ideally should have been had between the patient and that person, saying, you know what, I trust that you make the best decisions for me, but in the event that this happens, if I'm not able to speak, then this is what I would ideally like. Okay, again, a very ideal scenario. I just want to spend a moment on decision-making capacity when it comes to patients. And as doctors, all of you, I know that you probably do this instinctively on a regular basis, where you are assessing the patient's decision-making capacity. And with your experience and training, and because you do this constantly, you're able to pick this up. And sometimes you're not even doing it, consciously. It's just part of your experience and expertise. We know that a person has decision-making capacity if she can describe a current situation or illness, when they are able to describe the consequences of a particular treatment, and when they're able to reason and show judgment. Okay, if I do this, then this will happen. If I do this, this will happen. Okay, I get it. Okay. And if the patient can speak coherently, ideally their choices and decisions come first, even if that choice is to let someone else make that choice. So we need to be mindful of this. If we are not quite clear about the patient's decision-making capacity, then there is a semi-structured sort of interview that you can do to establish that. And I'll be sharing a link to a paper that Dr. Roop Gursahani has shared with me as well about decision-making capacity and how it can be assessed. And this is important because this will then help us set the foundation of how we're going to proceed. Who is going to be leading this decision-making process? Okay, now, there are 3 locations of care, and this is important when it comes to communication. There is the hospital, and typically we see people being treated in the hospital for acute care, for procedural interventions, close monitoring of symptoms, and it depends on the affordability of the patient, if the patient can afford to be in the hospital for a certain period of time. The second kind of setting is at home. Okay, and there we have to ensure whether they have access to support, and also what are the family dynamics really, who's going to be looking after this person. And finally, we have the hospice or nursing home or assisted living kind of a setting where it is for prolonged extended care. And again, affordability becomes, a question that we have to ask. And it also depends on the family's capacity to provide care. If there's only one person, one other person in the family, they have to go out and work. And for that, they have to leave the person somewhere where they can be taken care of. Then that is also a consideration. And in prescribing treatment options and having that communication, the setting is really important. We need to understand what is their preferred setting. So in the case of Mrs. D, the family said, we want to look after her at home. Now, if you are able to have empathetic communication, or you're able to, have a two-way conversation that is empathetic, taking in, and when I say empathetic, I mean, you're able to understand the situation that the family is in, what they're able to afford, what are their preferences, what are their values. That is being empathetic. Empathy does not just mean emotional empathy. Empathy means understanding the person's situation, even practically and socially. I am, as a trained psychologist, I am very, I'm not fond of the concept of walking, it's putting yourself in someone else's shoes. We will never be in somebody else's shoes, but we have to be able to see the world the way the person sees it. We don't want to put ourselves in the other person's shoes or become the other person, because that hampers our problem-solving ability. So in this case, I want to ask you, if you are able to take into consideration all these different things that I just shared with you, what benefit might you reap? What is the purpose of sitting and having these conversations of affordability, accessibility, prognostication, expectation? Why are we talking about this? How will it benefit you as a healthcare worker?
Discussing all these things will result in better compliance and better response to the treatment. Because as you mentioned, a few examples for that boy, he was prescribed the things without discussing, but he was not taking the treatment. So the whole treatment process was waste.
Yep, and 3 years gone.
Yeah, this is very, very common.
Yeah.
That is going to empower us to make a shared decision making.
Yes. And, shared decision making also means less burden on you. It also means that, there is better compliance with something that the person has agreed to do with you. Yes. With this information, we can give the best options to the family. Yes. We can fine tune our palliative care more effectively. Yes. What else?
Ultimately, when patients, we are consulting the patient and they are not getting recovered or cured, or at whatever stage they are, ultimately it leads to the doctor burnout also.
Yeah, excellent point. Absolutely. It might also lead to, if something has not worked, it might lead to anger towards the healthcare system, right? And that's something that we are experiencing a lot nowadays. There's a lot of animosity, and there's violence against doctors. There's all kinds of things. And I'm not saying all of those have to do with bad communication, because sometimes it's just unreasonable what is happening. But it does have an impact. Yeah, greater patient satisfaction, gratification, compliance, overall quality of care. So yes, there are lots of reasons why we should really focus on communication as a skill, because as you upgrade your clinical and technical skills, communication is as much a science as it is an art, and it is something that requires constant upgradation. So what are the benefits? You've already highlighted them for me. Removes uncertainty. One, information. There is a huge information vacuum that a lot of patients and families go through because they just don't know. And that is when the Dr. Googles come into the picture. That is when your WebMD comes into the picture. And so if you are able to sit down and explain, this is what it is. How much do you want to know? Where can we go with this? The information vacuum then shrinks, and patients feel more reassured in your presence. Patients and families can make informed choices. So they are entering into a partnership with you and saying, yes, we agree that these are the goals of care, and yes, these are the acceptable treatment interventions for me. It prevents unrealistic hope and loss of scarce resources. And okay, I want to spend a little bit of time on this. Okay, prevents unrealistic hope and loss of scarce resources. How many times have you encountered a patient who goes doctor shopping because they're not getting the information they want, and they're spending lots of money going from hospital to hospital, doctor to doctor, sometimes to quacks, spending all that money and then finally coming back home, coming back to your care. You can.
I have an example, but it's not
Yes.
with palliative care. It's more to do with diabetes care. So when you tell the patient that now you need to take insulin, they run away because of the phobia related to insulin is massive. And how much ever you try to explain to them that it's not as bad as you think that insulin is, because I mean, it's all hearsay information that they have gathered till now. So they feel insulin is either the last stage, मतलब अभी मेरे लिए कुछ नहीं हो सकता है, or they feel कि this is not a good drug and I'm going to collapse someday somewhere. So then they go doctor shopping, and then they do go to quacks, and then they are on multiple regimen of drugs, and then they come back after about 6 months, 8 months with even worse HbA1c that they were on, all because they wanted to avoid. So I'm not sure it fits into palliative care.
No, I think it fits into the general, service delivery model. And like in palliative care, we have a similar thing: opioids, morphine, and they'll run a mile. And unfortunately, in our scenario, we have other doctors telling them that no, you shouldn't be doing this. And we're questioned about legality, we're questioned about ethics, we're questioned about hastening death and euthanasia. And there is a lot of myth busting to be done. Unfortunately, Dimple, sometimes what we're doing is cleaning up the mess of somebody else's bad communication. They have not been given the information properly, and therefore we are now picking up the pieces. And there is, by then, they've gone to all those 15 quacks and other doctors. With every encounter, there is a lowering of trust because they're not getting what they want. By the time they come to you, the trust deficit is massive. So not only are you starting, you're not starting from zero, you're starting at -10. Because every one of those people along the way did not communicate effectively with them. So it's not easy. It's not going to change overnight. But I feel your pain when you talk about your experience, because half the battle here is like, when someone says, but my doctor told me that we are not there yet. For pain relief, for 10 mg of morphine every 4 hours, we're not there yet. How much pain does someone have to be experiencing for you to manage it? At what point does it become ethical? So that is a constant battle all of us are facing as well. So I completely, I empathize with you, in solidarity with your experience. But also when you're able to communicate, and not necessarily with the patient, because it's not always with the patient that we're communicating, but managing the hopes of the family so that that collusion comes down. Now, when we come to, and I'm not going to do a separate section on collusion, we're just going to talk about it as we go along. The problem with collusion is, what is it? It's the family standing guard saying, no, you will not talk to the patient. And when you ask the family, why not? What are the answers you get? What are some?
The patient will be more stressed if she knows the actual prognosis. She will go into anxiety. She is already so weak. So letting her know this thing will make her so dismay, and this will have overall ill effect. That's for the most of the answers.
Punita, I saw you unmuting.
Yeah, I was about to tell the same. They'll tell that patient is too weak. You cannot break the bad news to them. We will tell it later. Give us some time.
Yeah. And can't stand the news. Somebody's a
They
patient.
always believe that they know the patient better than us because they are family people. So they.
But actually, the patient does know if something is happening very unfortunate with her, but there is no acknowledgement by the patient, because even if he or she asks the question to the caregivers, they just deny that one. Yes, everything will be all right. It is nothing, just an infection. They're just curing for this thing. So even she encounters the question with the caregivers, they just outline it. Yeah, it's nothing much to think about it. It's just an infection or just something, a source of cyst that can be cured of. So this makes the patient also in collusion. Yeah, already the trusted caregivers has given me this answer. See, nothing much bad is gonna happen. Why should I ask the same question to a doctor? So again, it becomes something like wall between the same question, how many times should I ask? But the body, the thing, the patient will does know something is happening, but nobody is addressing my things. Nobody is telling actual factual reasons to me, and already everybody is just telling some other stories or some other things, but not actually addressing my issues. This makes the patient also feel anxious
Yeah,
by
absolutely.
not letting.
Yeah, absolutely. So here's the thing. I'm picking up on these things, okay? Like you said, the patient, the caregiver thinks they know the patient best. So they're deciding this. There are often times, like Ravi just said, that the patient knows something is going on. Now, imagine somebody who is educated and is being taken to the oncology department every day, is seeing other patients, is overhearing conversations. And then we're just gaslighting them into saying, no, nothing's wrong, everything is fine. Sometimes it might also be that the patient is, it's such an uncomfortable conversation for the caregivers that the patient also doesn't want to contribute to the overall anxiety of the family and plays along. Okay, I'm not going to address this. They will tell me when they're ready to tell me. Sometimes the patient is ready to ask the doctor, but one caregiver will come and stand and like make eyes at the doctor from the back. No? I can see from the reactions that all of you had that experience. So you're in a fix. You don't want to betray the trust of the family. You know the patient wants to know, they know something. Now, in psychology, we have something called gestalt. Gestalt means the whole is greater than the sum of its parts. But what gestalt also talks about is the fact that when we don't have the full information, we fill the gaps. The human mind is designed to fill gaps. And when we don't have enough information, the tendency is to fill gaps with imagination. And sometimes imagination is far worse than fact, which makes it even more important for us to have the facts. But collusion is not an easy thing, especially not in India, where we do not really consider the autonomy of the patient. The minute somebody has a diagnosis, they are a patient. They have stopped being the head of the family for the last 50 years. They have stopped. Now, tomorrow, when someone said they understand their families best, if you were to actually sit down with the patient, with the caregiver and say, tell me about your father. What sort of a person was he? Oh, he was very dominating. He was always in charge. He took all the decisions. So what makes you think that he is going to fall apart right now? So in collusion, what my recommendation to you is, there is always a fear that the family has, which might be completely unfounded. Don't try to bypass the family to go to the patient. The family deserves to be sat with and elicit their fear. What are you afraid of? I'm afraid that he can't handle it. What do you think will happen? How do you think he's going to react? Tell me how your father has reacted to crisis in the past. Is this the first crisis he's experienced? He tends to get angry. He tends to do what? There are ways that we can handle it. I also want to make a case for death anxiety versus medical anxiety. We think every human being is afraid of death. That might be partially true, but in a lot of cases in serious illness, it's not so much dying, it's the process of dying. People are scared that they'll suffocate. People are scared that they'll be in pain. People are scared that it's going to, it's going to be horrific. They're going to lose bowel control. They're going to lose cognition. And sometimes sitting with the patient and reassuring them that we have ways to address that. You will not suffocate to death. Our team is here to make sure of that. That takes away the fear. So, but sometimes that conversation needs to be had with the caregiver first. And that's how we work with collusion. Okay, I'm mindful of the time, so I'm just going to move along. And good communication also gives the opportunity to express emotions. Yeah, you want to hear from the family where they're at. You want to hear from patients where they're at. And like you said, it leads to better compliance. I will trust my doctor if my doctor takes the time to sit and talk to me and explain things to me. I will automatically gravitate towards him or her. And if my doctor is able to explain things better to me, is able to lay down the pros, cons, etc., is showing me that he or she is on my side, I am likely to go with that person's recommendations. So coming to what is bad news? What is bad news? Bad news is any information which drastically and negatively alters a person's view of the future. So I'm going to give you some news, and suddenly the future has changed for the worse for you. I'm no longer able to walk. I'm going to need a catheter. I'm going to need to stop driving. I'm going to need to move to a liquid diet. I'm going to need to, take medications that are going to make me drowsy sometimes. Okay. The greater the gap between someone's expectations of the reality and the reality of the situation, the worse the news will be. So this is, as you go along the illness trajectory, if I'm expecting a full recovery from a 4th stage, 4th grade lung cancer, and what the reports are telling me is that I'm not responding to the medication, the gap between my expectation and the reality is so much that the news is going to hit me harder. But if I'm more in step with, okay, I know that this is a serious diagnosis, we're going to try these things out, they may or may not work. It's not that it's not going to be difficult. It's just that the intensity of that is going to be a little more manageable, okay, because you're setting realistic expectations. Now, I'm just going to give you a scenario, yeah? So coming back to Mrs. D, she's been recommended physiotherapy, pulmonary rehab and physiotherapy, okay? So she's starting on the physiotherapy and she asks you a question. Doctor, when will I get completely okay? We know she has rapidly advancing idiopathic interstitial lung disease. Now, what if the doctor says, I'm sorry to say, but this cannot become completely okay? That is the response. How do you think that's going to land? What is missing in this response?
Empathy.
Empathy.
It's very quickly given response.
He has failed to know, to try to gauge how much the patient knows, what is her perception of the disease, how much she's open to to being told anything further. And, accordingly, he should have given her the information.
Okay. So let's be specific. Mrs. D is starting physiotherapy today. She asks you, when will I be completely okay? Tell me the specific sentence that you're going to say to Mrs. D.
We would say, let us start with the physiotherapy and see how you progress. You may not completely be okay, but you will definitely get much better gradually with time.
Okay. Any other responses? That is a kinder response, Nikhil. And it's a more realistic response for sure. Yes.
Hello.
Ask her whatever is bothering her right now, and we can try addressing one after the other.
So I'm going to, I can't see who just said that.
Hi, this is Dr. Priya.
Yes, please.
Yeah, we can start by asking her, what does she know about her illness?
Okay. I'm sorry, I'm just going to stop you for a second, Priya, and also the person who spoke before. You are describing the overall scenario. What I would like from you is the sentence you will use. You're talking to me. I'm Mrs. D. What will you say to me, Priya?
Like the premise is when she asks you that, when am I going to get better?
Yeah, when am I going to get better, Dr. Priya? So you're talking to me. I'm Mrs. D.
That's so difficult. That's so difficult actually, because in one line to tell that is very difficult. I would just ask her, no, I would just
tell me.
You're the patient.
Yeah.
Try to get an idea of what is completely okay. I mean, what does she mean by completely okay? What is it that she wants to do?
Simple. I am she. Talk to me. Tell me.
Let us take it one step at a time. I will tell Mrs. D, let us take it one step at a time.
It's okay. It's all right. It's okay.
Yeah.
It's difficult.
Mrs. D, can we discuss the disease first?
You asking me? Can we discuss the disease first? Dr. Ramesh, I just want to know, you're making me do this physiotherapy. If I do this physiotherapy, will I recover?
Madam, we can ask by asking the patient how much she knows about the disease and how much she wants to know about the disease.
Ask me, Biju, ask me.
Madam, how much do you know about your disease?
See, I just know that I was fine 6 months ago. Suddenly I can't breathe. And now they're telling me to do this physiotherapy. So if I do this physiotherapy, I'll be fine, no?
Would you like to know more about your disease before we answer that question?
Okay, you're scaring me a little bit, but okay.
Well, how much would you like to know? Would you like to know the whole thing or just what is required?
How much is there to know? Is there a lot that I don't know yet?
This is a chronic progressive disease. And so if you would like to know more about it, I can tell about it, but there is no actual cure to it, but we can continue to mitigate the symptoms and keep you comfortable with our palliative care.
So what do you mean by mitigate the symptoms?
Like breathlessness, which you had a while ago, that can be taken care of to a lot of extent, and associated symptoms along with that. Like if there are any infections, we can take care of it. But the disease is progressive. So if you would like to know more about that, we can talk about it. We can discuss.
No, I'm telling you, I want to know about it.
Okay.
Okay.
But
Okay.
if you-
So I'll stop you here. I'll stop you here. I'll stop you here. Okay. Pushed you into a corner enough. But see, this is it. This is it. Okay. So it's easier to describe it theoretically. I will talk. We should ask the patient how much they know. What is the sentence? And then what you're going to do next? Once she tells you, I don't know anything. I read, whatever it's called, it's some idiot something, it's called something. Anyway, I looked on Google and it said, I should also do a lot of like steam inhalation and stuff. So, but I think I'll be fine. So see, the thing is, be prepared for these questions. And it takes a little bit of role playing to do this. Yeah. It's like I said, it's easier to zoom out and talk about it, but it's harder to get into it and actually arrive at the words that you want to say. Okay, so we'll keep trying to do this. I'm going to go back to the presentation, and Dr.
We have to give it bit by bit.
Yes, we have to give
and see how much she takes.
Yes, but not necessarily all in that same session. Okay.
Yeah.
Ideally, I would say also, let's try and get the caregiver present over there. Dr. Sunil, if I'm missing anything important, please do point it out to me. But for the time being, I'm just going to move ahead because I really take up too much time. I know we have a case presentation as well. Okay, so we know that there are different ways to handle it. What this person said was very clipped. Maybe it reflects a little bit of his own fear, like, oh my God, I've been suddenly asked this question. It also shows a lack of preparedness for this question. So if you are working with a person with a serious illness, it's always good to prepare a little bit in case this question suddenly catches you off guard. Okay, are you familiar with the spikes protocol? Dr. Sunil, was it taken the last time? Sorry.
No.
So this is typically a spikes protocol is whenever when we're looking to communicate bad news. Now, this is something we're initiating. What happened in the previous slide is Mrs. D suddenly asked you. But here, when you know that there is bad news to deliver, whether it is reports have not come back properly, I mean, or the outcomes are not that great, treatment is not, there's no response to the treatment, so on and so forth. Try and get this going, okay? Spikes. Now, make sure that the setting that you're having the conversation with the patient or the family is somewhere where you can give them your full attention, okay? I know it's not always possible to get a quiet room in a hospital or in an OPD. It's sometimes, it's a phone call, but how do you give them your full attention? Even if there's lots of noise and stuff happening, maybe put aside other stuff. Your body language also will contribute to the setting. Yeah, you have to show them that they've got your full attention. Don't look at your watch, don't look at your phone. Make eye contact, okay? And if you can, if there's a curtain that you can draw, that adds to the sense of privacy, that adds to the sense of cutting out other stimulation. Perception, how the patient perceives the medical situation. Like many of you said, how much does she know about the illness? So for me, the question would be, you know what, I'm really interested to know how this whole, how this has been for you the last few weeks, ever since you started treatment. Open-ended. I believe in storytelling. Okay, I want to hear the person's story. Tell me this. It's not like saying tell me the story of your illness, but tell me what the last few weeks have been like for you. Yeah, and tell me also about how you're feeling, and you know what do you think is going on with you at the moment. Invitation. Ask the patient how much information he or she wants. Okay, so you know we've run the tests, we've done the blood tests, and we've got back the results, and there's a lot of information in here, but you know I'm just wondering how much of it you want to know. And or it could be that you know we've done this test and the test results have come back, and I'm going to just I'm going to take you through a couple of other tips on how to navigate this particular invitation. Okay, so we want to know how much the patient wants to know, but there's a couple of considerations for you, which I'll take you through in the next couple of slides. Once the patient says, okay, yeah, please tell me now, am I going to be able to, you know, get back on my feet? Are my energy levels going to get better, etc., etc.? You provide the information that the patient wants, and respond with empathy. You know, I know this has been a pretty difficult time for you and your family, and you're hoping for good results. We're doing our best to make sure that you at least feel better from a day-to-day perspective. Strategy and summary at the end of every meeting. Okay, so they've come, you've had a chit chat with them to see where they're at. You've given them the information, you've expressed your empathy, and towards the end, say, okay, so based on what we have with the findings, you know, these are some of the ways in which we can move forward. Again, decision-making, information, recommendation, values and preferences, affordability, accessibility. Have that conversation, summarize, and that's the end of your meeting. I know all of you do not have copious amounts of time to do this, but typically in an ideal scenario, the spikes protocol is what we follow. Now, very important, who in the team is going to communicate the bad news? And who are you going to talk to in the family? What are the 2 points of the interface? Is it going to be the doctor? Is it the nurse? Is it going to be the social worker? Who is it? And who are you going to talk to? Is it the primary caregiver? Is it the patient? Is it the patient's financier who is sitting in Dubai? What are you going to tell them and when? So as the trajectory moves ahead, the impact of treatment, concerns, challenges, these are some of the things that you're going to be discussing. How are you going to communicate? Through the spikes protocol, okay? And you need to also let the patient set the agenda. Okay, who is the best person to deliver bad news? Who is the best person to deliver bad news?
Main consulting doctor.
Okay. Anyone else?
Nobody wishes to deliver bad news to anyone.
Yeah, that's true. Nobody wishes to deliver bad news. Someone's got to do it. As they say, someone's got to bell the cat.
Someone who is very adept in communication.
It's the palliative care physician.
Ah, see.
No, actually, it should be the main treating doctor who has been with the patient from the start of the journey.
Yeah,
But in today's day and age, we see multiple doctors, no?
The bedside
The
nurse.
primary treating consultant.
Bedside nurse.
it's the primary care physician who is the
Primary
most
treating
appropriate person. Yes.
But what if it's a super specialized part of this thing? Like, you know, there's a particular report that a specialist has been brought in and he's just consulted and gone. Then?
I'm still
I
saying
think
the
the person
primary
who knows more about the patient history should communicate.
Oh, it's Dr. Raju. Hi. I just.
Hello.
Okay. I started my palliative care journey in pallium at the same time.
Together.
So, Dr. Sunil, please don't panic. I'm looking at the time. Okay. So I will try and wind up in the next few minutes. Okay.
No, by experience, it's very important that the primary care physician takes that role. It's very, very important because he has got the trust of the patient and he's got the maximum rapport with the patient. He'll be the right person to deliver it.
All right. I mean, not to discount what you're saying, but I've had people who have this primary care physician who is so senior in the organization and in the department who barely spends 5 minutes at a time with the patient, zero rapport, but is more top down. So that's also something to consider. Yeah. Those who the patient knows and trusts. And sometimes they just trust blatantly because of the credentials of the person. It's not necessary that there's any rapport building that has happened. He is the best in the business. Fine. Is this what he's saying? Okay, so be it. Those who have the skills of conveying the message. Some of you said those who have the communication skills. Yeah. We're not born with those skills. We have to cultivate them. And those who can handle the reactions effectively. What happens if it's really bad news and the patient completely breaks down? Is there anyone to pick up those pieces? Those who know the disease, the prognosis, and the treatment. So sometimes it cannot be the social worker. Sometimes it has to be the doctor, or the doctor has to be present. Sometimes it's somebody who's worked with the patient for a long time.
Let the patient show his emotion.
Yes. Yeah, and somebody who's comfortable with that. You know, somebody who's able to, okay, sit and maybe not, you know, comfort them greatly, but say something.
If anybody wants to do palliative medicine, they have to become that.
Yeah, they have to become that. I think not just palliative care. How about telling a close person who then communicates to the person? We never know how that person is going to share the news. This is Chinese whispers. And also we are putting pressure on that person. Please remember that that person is also somebody who has to live with the aftermath. And there's always a, you know, slight element of doubt, because are you sure you understood the doctor properly? I want to talk to the doctor. I don't think you understood correctly. Okay. Now, when should we be communicating with the patient? Sharing information is an ongoing process. Okay. And it's the in-between good bits also that we need to keep communicating with the patient. You can't just keep coming in and giving bad news all the time. No? You need to also come in and talk to them on a regular basis. And that also builds the trust and the rapport. When the patient asks, provided the patient has been given the opportunity to ask.
We have to give it in small chunks and see how the patient takes. It may take more than one session.
It might take more than 5 sessions, but when we say, yeah, I'll tell the patient when they ask. But if we walk in like a whirlwind, give the reports, give the information and leave, have we given the person an opportunity to ask, right? So one is to actively ensure that you are giving that person the opportunity to ask by the spikes protocol, okay? Okay, context. Facts must be equipped. The person who is delivering the news should be equipped with good idea of medical history and progress. Somebody who knows the case or who has been briefed properly about the case. Okay? A safe environment. Okay, I wouldn't say, I mean, like I said, a quiet room is not always possible. No disturbance is not always possible, but we can give the person a sense of safety by our presence.
Body language should be right.
Body language is very important. And how do you do it? Now, suppose I'm giving bad news. Now, this comes in the spikes protocol. This is the information giving part. Okay. First of all, I'm going to declare my agenda. Today, I'd like to discuss with you the reports of the tests we did the last time. So I'm telling them upfront why we are meeting. Okay. That's why I've called you today. We're going to discuss the reports. Before we get started, I just want to know, what you'd like to get out of our visit today, or where it doesn't necessarily have to be this sentence, but we could just say, so, I just want to know how things are with you. Do you have any particular concerns at the moment? Now, the patient might turn around and tell you, yeah, doctor, haven't been sleeping well. I find that I'm just, my stomach is it's not okay. Sometimes I'm constipated, sometimes I'm not. And I'm just so stressed all the time. So they're giving you a list of things that is worrying them. Okay. But you're here to focus on something important. So you have to negotiate the agenda, in which case you say something empathetic, which makes them feel that, yes, these are important things. There may be more on your list than we have time to discuss. But out of all of these things, which items do you prioritize as most important? So he'd say, yeah, my sleep. So address the thing that the person feels is most important, and then come back to what you're here to to discuss. Okay. Yeah, yes, Nikhil, you can say that, but then be careful of what you're opening yourself up to, because a whole other kettle of fish, right? So we'll come back to that. Okay, now invite other decision makers. Who do you usually rely on to help you make important decisions? My daughter, my son, my father. Okay, when you come to see us, or it'll be great perhaps if you could bring them along. When we discuss your results, who would you like to be present? So you have to invite other decision makers. And this is something that you need to do before you actually have the conversation. This in itself is telling them that this is going to be a serious conversation. Now, when you're breaking the bad news, first of all, is more information wanted? Now, you don't withhold information if the patient or relatives want to know, but at the same time, you don't want to impose information when the patient does not want to know. It's not necessary that you have to tell them the truth, the whole truth. You have to wait. You have to let them set the agenda. But how do you know whether the person wants it or not? They might say, I don't want to know, doctor. It's enough if you give me relief from breathlessness. The conversation ends there. But then you check. Okay, now coming back, tell me what you understand about your diagnosis. It's always important to keep checking this because patients' understanding changes depending on their emotional state. Check the patient's medical knowledge. We have, we're now living in a time where patients and families have the whole vocabulary of oncology. They can rattle off, phrases from cardiology. They can tell you names. I mean, come on, during COVID, everybody knew all the drug names and everyone thought.
They speak in short forms also.
Yes,
Even,
yeah, abbreviations.
abbreviation.
Everybody talked about the cytokine storms. Everyone talked about that. Yeah, but check the patient's medical knowledge. So we've been talking about interstitial lung disease, ALL, CVA. What do you understand about this condition? Many people will tell you, oh, I don't know, the kind of cancer. Do they know that there are different kinds of cancer? What does ALL really mean? Okay, and patient preference for information. How much do you want to know? Okay, now here's a very, very important part. How do you know when to proceed and when to stop? There's a warning shot. And the warning shot looks like this. It is more serious than we thought. Or the disease is progressing despite our best efforts. There are many examples of this. And I'm going to try and wind this up quickly. Sorry, I'm overshooting quite a bit. This is possibly one of the most important parts of breaking bad news. This is where you check and you wait. And the patient will say, oh, okay, all right. And they will lead you and say, okay, you know what, actually, why don't I come back with my brother? That tells you that this patient is not ready to receive it. Or they might say, okay, you know what, just tell me. I just want to know how much time I have. So this is the point. The warning shot is the point which decides the rest of the conversation. So learn how to give this warning shot in your own settings. Pause and allow it to sink in. You might have a lot of different reactions. There could be crying, there could be silence, there could be, anger, whatever. And they might start bargaining with you. Or they might say, is my internet unstable?
No, ma'am, it's a participant getting unmuted. You can come.
Okay, fine. And or they might fully accept, or they might tell you that, you know what, I knew something was horribly wrong. I'm just really relieved to have all the information and stop guessing. There could be a series of different responses that you might get. And empathetic statements at this point is, are you able to tell me how you're feeling after receiving this news? I can, or simply just naming what you are seeing. I can see how upsetting this is for you. I can see how hard this is for you. This must be very difficult to hear. These are empathetic statements. Don't rush in to fix the emotion and say, don't worry, everything is going to be all right. You can just sit and allow you have to sit and allow the emotion to happen. Okay. And please, these are simple do's and don'ts. I'm going to stop with this. Don't avoid eye contact. Make eye contact. Culturally appropriate eye contact. You can't be like staring at them like this. Culturally appropriate eye contact. Don't rush in to tell the truth. Warning shots are necessary. Look at the body language. If they recoil, if they start getting nervous, look at all of that. They might ask you a question, when will I die? Or how long do I have to live? A lot of doctors feel pressured when this question comes to them, right? And it's not a fair question, but you know, I think prognostication of that sort takes a lot of time and experience and skill, but even then we're not ready to answer this question. So don't answer the direct question. You can ask a counter question like, why do you ask? Is there anything in particular that is bothering you or you want to do? Please don't ask leading questions like, your pain is better now, isn't it? There's only one way to answer that, yes or no. Ask open-ended questions. Don't minimize or compare the patient's problems. You know, don't worry about this. This happens all the time. There's a patient in the ward. You know what all she has and how brave she's being. So why are you behaving like this? Instead, normalize the person's emotional response and say, yes, you know, it's normal for you to feel like this. Don't give false hope by saying things like everything will be all right. Give realistic hope. Your disease might be progressive, but we'll do our best to address each of these symptoms that you're experiencing. And we'll be there for you as things progress. And don't assume you know what they want, that they want medication, that they want certain interventions. Ask this question. It is a magic question. What is your biggest concern right now? It might not be recovery and cure. It might be, how am I going to feed my children? So these are the do's and don'ts. I'm very sorry I've gone way over time. So Dr. Sunil, I'll stop now and turn it over to you. I will leave this group with the case study one more time, which is, I want you to please go over this. And when time allows you, there are several ways, there are several points to have breakpoint important conversations. I want you to think about which of these different points you need to have very important breaking bad news conversations. Okay, so go over this again based on what we've talked about and put yourself in these scenarios and what you would say to the patients and families at different times. So I will stop sharing my screen.
Okay, thank you, Smriti. I think we will take questions after this presentation because the patient story is related to communicating bad news. So today's patient story will be presented by Dr. Leanda from Indonesia. Dr. Leanda.
Yes, thank you, doctor. Let me share my screen first. Thank you, Ma'am Smriti Rana, for the excellent presentation. Good evening, everyone. Thank you for the opportunity to present today. My name is Leanda. I'm pediatrician from Indonesia. So today I will presenting case about 2 years old boy diagnosis with Burkitt lymphoma. So this is the boy came with chief complaint mass at the right eye, since 1 month with pale fever and weight loss. This picture show us the appearance of the mass. These are the history of the illness. 1 month ago, the right eye getting redness and growing mass progressively in 2 weeks. Because the patient is live in remote village with limited access for the health care, so the parent took him to shaman and get herbal ointment. At time patient can reach hospital, the mass is getting bigger and have pus on it. Patient also complained with fever and look pale. From physical examination, patient still full alert with multiple palpable lymph nodes on neck and axilla. The mass at right oculi, others in normal limit. From laboratory finding, there are decreased level of hemoglobin and increase of leukocyte. Biopsy results show orbital Burkitt lymphoma with differential diagnosis embryonal rhabdomyosarcoma. We confirm the diagnosis with immunohistochemistry result lymphoma malignant non-Hodgkin B-cell high-grade Burkitt lymphoma. The ophthalmologist done right oculi total excentuation. After patient condition stable enough, we do chemotherapy. But during the first cycle, patient got seizure with status epilepticus. The CT and the LCS analysis confirm there is a brain metastasis. From psychosocial aspects, such as the boy is the only child with teenage mother, father and mother not a married couple, and the father left the family behind the village. Mother worked as a farmer and low educated also. Mother lived with her parents, also a farmers. They live in the remote area. To reach our hospital, they have to travel 24/7 by ship and land road that have not been paved. The mother has a great hope that her child will recover because he has to travel a long and difficult journey. He becomes sunshine for his mother and the hope for her mother who live a bitter life. This is the map of our country, Indonesia. Our hospital in here in different island from Central Hospital in Jakarta as the nation capital and national referral center, which also we have a limited access for advanced lab and treatment. So the biopsy results are obtained by sending samples by flight. It makes such a delay in diagnosis and treatment. We treat the patient with phenytoin for seizure management, the antibiotic for secondary infection, and wound treatment for post-excentuation operation. We inform mother about the importance of palliative care, from emotional support, pain management, to assistance to family while in the hospital. In this video, we can see the patient will discharge, and he has been in our hospital for almost 3 months, and now she's in fully alert and ready to go home. There is main concern in this patient. There is the poor prognosis due to the brain metastasis, and the mother finds it difficult to accept the condition of her only son. Other concerns are these are no community-based palliative care facilities available in our area in West Borneo. The patient was difficult access to healthcare facility. And the last but most important things in our culture is taboo to talk about death. As a summary, 2-year-old boy diagnosed with orbital dextroburkid lymphoma stage 4 with brain metastasis, anosmia post-total excentuation, patient treated with seizure management, antibiotic, and wound treatment. The biggest challenge in the family acceptance for the poor prognosis. As we realize the role of the family, values in culture, pediatric palliative care such as decision maker for goal of care, do the most communication, verbal and also non-verbal, how they understand the meaning of illness, dying, and death, and also the preferred place of care and death. There are 3 points to be discussed. First, how to communicate about terminal illness to a child. Second, how to deliver bad news to the parent. Third, how to honoring family values and culture during conversation with serious ill children. Let's bring us to the end of the presentation. I sincerely appreciate that I have the opportunity to present to you all. Thank you.
Thank you, Dr. Leanda. So, Dr. Leanda presented a story of a 2-year-old boy who had Burkitt's lymphoma and underwent acceleration along with and he developed brain metastasis. So she's asking about the communication to a child who is seriously ill. Can any of you have any comments on how to do this? Anybody who works in in pediatrics? I hope I am audible.
Yes, sir.
Okay.
No, sir, not working in this direction. But then what I was thinking, it is so difficult regarding the affordability of care, and also accessibility also plays a lot of role.
Yes, but that's correct. But we need to have some comments on communicating the terminal illness to a child. Anybody? Smriti, would you like to?
Sure. Can we stop screen sharing? So when communication, when there's a child involved, is of course different. We have to take into consideration the age of the child. This is a 2-year-old child. And like someone rightly pointed out in the chat, this child is not going to understand prognosis and things like that. Here, the primary focus, in my opinion, others are welcome to disagree, is management of emotions of the patient's family, and particularly the mother, who is clearly very distressed. There are cultural barriers to communication. There is taboos and stigma around talking about death and dying and so on. In communicating when it is a child, I will also taking the child as the focus. We have to remember that different children at different ages are able to understand information differently. A 4-year-old, a 5-year-old, a 10-year-old, a 12-year-old, a 16-year-old will understand information differently, purely because of their neurobiological development. An 8-year-old is going to take things literally. A 14-year-old is able to understand metaphors and euphemisms and abstract concepts. If you're talking about, like, say, a terminal illness or death and dying, even if about somebody else in the family, and say, oh, the grandmother died, child says, what happened? She went to sleep and never woke up. An 8-year-old is going to take it literally. And what you might do there is unknowingly cultivate a fear of going to sleep. Oh, this person was very loved by God, so went to live with God. Suddenly this child is like, I don't want God to love my mother so much. It's literal. A 14-year-old is able to understand it differently. The importance is honesty, and honesty with children is difficult because, we're afraid of saying the wrong thing. But there is, just like we check with adults, what do you understand about what is going on with you right now? You have to let the child, who is coherent and is able to talk, also set the agenda. They will use different ways of telling you what they understand. But then that again requires some skill development on our side. Okay, there's a tendency to protect children. There's a tendency to not go there, or to assume that a child will not understand. Children understand things in their own way, but to understand how much they understand, you have to let them express themselves. And just like gaps in information are filled with imagination, please understand children's imagination is far greater than ours. So they will also describe it to you in different ways. Okay, so that is about that. In this case, managing the mother and the father, and Leanda, did you say that they're teenagers themselves?
Yes, it's just 17 years old.
They're not adults. They're still legally children. So let's address that. Okay, 17, 18 is a time of hormonal changes. It's a time of emotional volatility. It's a time of, they're still children. So always start there. What do you understand? And actually, I find personally, and Dr. Sunil, maybe you can back me up on this, sometimes the patient or the family will surprise you with what they tell you. Okay. Now, obviously, these are two young people who are in a situation they probably didn't mean to get into, getting pregnant as teenagers. They're not married. They probably don't have the social support that a married family would have, married couple would have. So what is their social support at this point? Because you alone cannot support them. Who is there on their side? they've gone and they've had a child when they were 15 years old. If they're 17 and the child is 2, they've had the child when they were 15 years old. So who is there? Sorry, did I miss that? She's a single parent. She's a single mother. There's no father.
Yes,
Sorry.
it's true.
Okay, sorry, I missed that. So here's the scene. Who is supporting her? First of all, I would say, look at what we call the eco map. Who is there in her slipstream? Who is there in her family who's able to support her with all this difficult stuff? That would be, in my opinion, task number one. When you give her information, who does she go back and confide to? Who does she rely on to help her make these decisions? Maybe that is the person you need to bring into this conversation, because she's not going to be able to tackle this alone. So I would start there, Dr. Sunil, and I'm happy to hear from others.
Any comments? Anybody?
Ma'am, I have a question. Is there any age cutoff at which you communicate directly to the child? Because I mean, in this case, 2 years old, you will talk to the mother, but like you said, a 4-year-old understands differently. So, I mean, is there an age when you directly tell the child also?
So I'm just going to reiterate, I'm not a doctor, but I have worked with pediatric palliative care. I don't think there is a set age. I think, but parental consent is very important. If you're going to be engaging directly with the child, the parent or the caregiver, whoever the primary caregiver, has to be aware of this. And there are times when the children exhibit exceeding wisdom sometimes. They know that the parents are scared. So they might approach you separately. I've had a 13-year-old ask me, okay, my mother's not in the room. Can you tell me what's going on? So I have to ensure that I still have the trust of this child, that they can approach me and say, again, my deflection there would be, what do you know so far? What is your understanding? See, I think something serious is wrong. Okay, but my parents just won't tell me. They keep telling me everything is going to be fine. Everything is going to be fine. I know I'm not feeling well. So I think they're hiding something from me. Okay, so tell me what you know. Tell me what this is like for you. And they'll tell you. Now, you can say, there is a lot for me there's a lot that I would like to share with you, but your mother is really concerned about you. So how about I have a conversation with her and you together? Okay. So there is no set, to come back to your specific question, there is no set age, but parental consent is absolutely important, no matter what the age of the child is.
Now, what I would...
Ma'am, but in this case, the parent is also a minor only, no, ma'am? She's just 15 years old. She's not an adult.
That's why I said we need to know who's there in her family who can support and guide her. She's in a very difficult situation. She is a mother, irrespective. But she is going to need additional support, far more than maybe a 25 or a 30-year-old mother might have needed, right? So, yeah. Sorry, Dr. Sunil.
Yeah, I just want to add something. Usually, the children, they would pretend that they don't know anything. So they actually want to protect their parents from the emotional trauma of getting this, and that the child knows about the terminal illness. And usually, what is seen in literature is these children, those who have serious illness, they have their peers. So whenever they meet the peers in the hospital, they talk each other. They understand what is your problem. My problem is this. What is yours? So they will share the information, and whenever they don't see somebody in the next visit, they will ask, where is the other person? Somebody might tell he died. So this patients who have serious illness, children especially, they talk each other and they get information from the peers, and they actually have a lot of information than the parents, and they just pretend that they don't know anything. So that is to protect their parents. We should also understand that even though they are children, they might know many things. So in presence of their parents, they might not open up to. So maybe even it is better to talk to them alone, so that they will come up with many things.
Dr. Sunil,
Yeah.
I'll just add one more thing to that, which is even if you, it's important to understand why you need to tell the parent that there might be a conversation I need to have with your child one-on-one, because they might open up to me. Okay, so that has to happen. And then you have to assure the parent that it's going to be a safe conversation. Just as a last point to this, there are 3 guiding rules of working with children. Okay, one is children have this sense of egocentricity, which means that they are the center of their worlds. It's not a selfish thing. A child does believe that everything happening in the world is somehow connected to them, which means that I am sick because I did something wrong. My grandmother is sick because I wish something bad would happen to her. They pull a direct link from themselves to what is happening around them. This is a fact. It's a psychological fact. So one is to try and mitigate the guilt. You are not responsible for what is happening to you right now. Okay, this is something that has happened as a result of XYZ. No, you didn't do anything wrong for you to get this disease. One, egocentricity. The second thing is every child has an understanding of death and dying, whether you know it or not. Okay, but they may not understand that it is an irreversible thing. Like for a child, a very young child, they don't understand the irreversibility of death, or they might think that death is something that only happens as a result of violence or a car crash or something. They don't see it as something, I'm feeling fine, so it's not going to happen to me. So understand that children have some sense of death and dying. And a really handy way of getting their understanding, especially if they're not very verbal, is using art. Get them to draw something, get them to draw, get them to use art, get them to use play. Observe them as they play, observe them as they draw, because you're going to get a lot of what is in their unconscious repository through what they express non-verbally. And the last thing is that irrespective of age, all children need reassurance. Even if their disease is terminal, they need reassurance that there are going to be safe adults around them. They need reassurance that just because one person, their sibling has died, their mother is not going to die next. So depending on the context in which you're engaging with the child, please know that every child needs reassurance and they need information. They will fill gaps in information with their imagination. So understand their idea of death and dying, use art, use play, fill in the gaps of their information, and finally be reassuring. Your conversation with any child has to end on a reassuring note. Even if you're not reassuring them of cure, reassure them that someone is going to be with them at all times. All children need that. Sometimes that's the best you can do. And also know that you can't fix everything. So we have to also be kind to ourselves when dealing with children, because it's very, very emotionally charged when it's a child in our care. Sorry, I'm going to address this. If you have a one-on-one conversation with a 13 to 14-year-old after consent and the child, okay, confidentiality, tricky one in this scenario that you have described. Tells you something that is that they want to keep confidential. You have to first of all say that the child can trust you. But like in any therapeutic process, if what the child has shared with you can cause harm to the child, it cannot be kept confidential. If the child has any thoughts of self-harm, if the child has any thoughts of, I don't know, any thoughts that might that sabotage the child's well-being, you cannot keep it confidential. What you have to also say is, I'm part of a team, okay? And because we're all invested in your care, I'm going to need to talk to the other people who care about you so that we can take the best care of you. That's one way to do it. So not easy, depends from case to case. I'm giving you a very generic response, Nikhil, but it depends on what that exact information is that the child has shared with you. I don't know if we have time, Dr. Sunil, to discuss the legality of DNR.
Karishma?
Yes, ma'am, I had a question. As a radiation oncologist, we usually come right towards the end of the treatment in most cases. So the patient has already met a surgical oncologist had the tumor removed, met a medical oncologist, maybe gone through a few rounds of chemotherapy, but at no point has, the spikes protocol been addressed or the patient sat down and prognosis spoken about. And then he's coming to you with a very high sense of inflated hope and no idea about the prognosis whatsoever. So do we sit down and do everything as the first point of contact, or should we just forget it and make things, because in some indirect way, it is pointing fingers at your peers and saying that, what they did is not optimal. So it's really difficult, when the whole system doesn't work on the same premise, and you want to go the whole way and say everything to the patient for the patient's best. And how do we deal with such a situation?
Very tough one. But you are the expert in your field of radiation oncology. They're asking you a question about the disease status, and you are in a position to address certain aspects of it. It is well, I don't know, I will leave it to the others to guide us on this conversation as well. But as an expert on your own subject and your own specialty, I would think you're well within your right to answer the questions honestly. It is not you're not saying that, they did something wrong. You are expressing honesty in terms of what you're seeing in front of you. And if the patient is asking you the question, as we've talked about, when the patient asks, you have to respond. How do you respond in a way that doesn't undermine your peers? It's a tough one, but I would say stay in your lane, answer questions about what you can answer questions. You're not, yes.
What we can do is, we essentially don't have to point fingers at anybody saying that, their treatment didn't work or anything like that. We just have to pick it from the place where we are supposed to begin by saying that, in spite of all the best efforts of all the doctors, the disease has progressed. I think we can start off like that, so that would be a starting point, which doesn't, harm anybody. At the same time, we are trying to, address the situation the best way possible.
Absolutely. I think that's spot on. And as per medical ethics, you say first do no harm, and implicating your peers is doing harm. So beneficence, non-malfeasance, all of that comes into play in this kind of conversation as well. So answer the questions that you are able to answer them honestly. And like Dr. Biju said, that, you don't have to say that things went wrong, despite everybody's best efforts. This is where we're at the moment. Could be the way the conversation goes.
Ma'am, I have a question. I have never really broken bad news, but I'm not really very clear on this. When you say how much do you want to know, how I'm not clear on that. What does that mean? And I mean, obviously somebody would want to know everything. I mean, how do we? I'm really not clear. Could you please clarify this question on how do we phrase it?
I'll defer to Dr. Sunil, who routinely answers.
Patients comes to you and asking you, actually most of the communication tips, these are developed by the Western doctors, and sometimes it may not suit us. So what you can do is, you need not ask how much do you want to know, rather you can ask, do you want to know? And once they want to know, then as Smriti told, you can give a warning shot and then go on to talk. And at any point of time, if the patient says, yes, it's enough. So they may tell it verbally, or sometimes they may show it non-verbally also. They may not be interested in talking. So at that point, you have to understand that I am not interested to talk anymore. So that's the information that they want at that point of time. So you have to stop it there. But if the patient is showing much interest, okay, then you told that it is cancer. And what's the situation now? Patient might ask, is it treatable? So they might have many questions. So you can be guided by the patient. It is always guided by the patient, whatever be the situation. So you can actually give answers to what the patient asks. And as I told you, when they want to stop, they will show it by words or by non-verbal cues. What you want to know may not be appropriate for many of the patients for who is coming to us.
Thank you, sir.
So I think we have to wind up the session. I know that this is a very interesting subject, and we can go on talking regarding any of the communication aspects. Sorry. Smriti, thank you for being with us for today to have a very interactive session on various aspects of communication. And thank you, Dr. Leanda, for presenting a patient story, which was which was an excellent story and generated a lot of discussion. And pediatric patients, many of the doctors may not see. So that's the importance of talking about pediatric palliative care. And we know that there are many children who needs palliative care, but those who are getting palliative care will be very, very minimal. So thank you, Dr. Leanda. And thank you everybody for your active participation. So once again, thank you, Smriti.
Thank you, Smriti ma'am, because personally I have been seeing you. This is the 5th hour, I believe, of you addressing an audience. And I am with you for the 5th hour for the day. And still you were so vibrant and so active in handling all the queries. Thank you so much for that. And as coordinators, your sessions are an absolute guarantee for us. And this session has been no exception. Thank you so much. I believe everyone would agree to that. And thank you everyone for listening to her and expressing your views as well, because this is a very delicate topic. Communication is a very delicate topic, and which, as soon as I said, we could go on speaking for hours and hours. So thank you everyone for joining us for the evening, and with the promise that we will see you again with another different topic and yet another eminent faculty in the coming session. This is Sri Priya along with Ms. Smriti Rana and Dr. Sunil Kumar signing off from the Tips Eco Hub. Everyone take care, stay safe, happy Republic Day, enjoy your freedom. See you in the next session. Bye-bye.
Thanks, Priya, one of the best communicators in Pallium India. Thank you. Thank you. Pleasure to meet all of you. Good luck with the rest of the course. Thanks.
Thank you, ma'am.